And so one of the last questions that, I kind of want to reframe this case a little bit. Let's say that instead of being a completely rapid progressor, let's say that she actually makes it through the triplet regimen for 4 cycles, and then she goes on to maintenance pembro. And she does pretty well on that, and then you stop for whatever reason. And then she comes back to your clinic a few months later. Do you ever re-challenge? Do you ever go back? What do you think about doing?
Yeah, I mean, for me, I have a few cases where this has come up, and I re-challenge. I mean, in a setting where someone has responded to pembro, the reality is you don't really know what the active agent or agents are. You don't know if it's synergy or if it's the carbopem that's doing the lion's share of the work, or if the pembro has no activity. And so I think what that leaves you with is trying to take a look at their course and then, make a rational decision about, well, maybe I should re-challenge them if they didn't have a good response.
So Ben, would you re-challenge or think about re-challenging with another checkpoint inhibitor in that case?
I agree with Paul that I would be more comfortable going back to the regimen where the patient had garnered the benefit. And that's another discussion whether these checkpoint inhibitors are all the same or not in their activity in non-small cell lung cancer, given some discrepant data we've seen with these and similarly designed trials with different drugs. But I would probably go back if the patient had garnered a benefit and that benefit had been more than 6, 8, 9 months and had a treatment break. I think the question for me would I go back to the pemetrexed pembrolizumab, or would I go back to the triplet and restart over? I think this is where medicine becomes an art and not a science, and we have to use our best judgment on what we think would be most meaningful for the patient. But I'd probably re-challenge the patient. If this patient had never been off therapy, however, and had continued and then started to slowly putter along, I think this is where, again, I would consider second-line options with docetaxel with ramucirumab, even for if they're not rapidly progressing.
Mm-hmm. And so is that your favorite second-line regimen to go to after they've been on a triplet?
Outside of a clinical trial, for a fit patient, yes. But for me, again, I'm very ready to make a dose reduction with the docetaxel, and I don't start generally at 75. I'll start at 60 for most of my patients with the ramucirumab.
And I agree, it's my go-to, but with modifications. We know weekly docetaxel is better tolerated, not less effective than the every 3-week dosing. And so
What dose weekly do you use?
So it's, really 60 milligrams is worth a consideration. And if you're worried about additional toxicity, you bring it down lower, I think, just to see. So
Do you ever use
it is nab-paclitaxel? Yeah, so I've had difficulty getting it approved outside of the first-line setting. The places where I have is if someone has a hypersensitivity reaction, or even if the steroid pre-medication is causing an issue with diabetes, getting that approved. And so I have actually given ramucirumab in conjunction with nab-paclitaxel for that. It's gone okay. And there's no reason to suggest that angiogenesis inhibition would not play well with other chemotherapy agents.
Yeah, the data suggests that it does now, what's
exactly.
coming out, right?
Yeah,
so,
yeah.
So I think that we can close on this case, but I think what we've seen in lung cancer over the past 2 years is a rapid evolution in the frontline setting, where we now have enormous new therapies. And I think that trend is now going to extend into the salvage setting, because this is where we begin to see that we have so many unanswered questions and a knowledge gap, specifically in this immune refractory population. So we have, I think there's a lot of hope for these patients. For right now, in terms of salvage, I agree with you guys that docetaxel ram still is probably for our patients for immune therapy refractory is a very reasonable option to go to.